Hey guys, can you see me, hear me, listen to me? Good evening, Suraj. Am I audible and visible? If so, say me a hi. And guys who were on the app, can you see the lecture on the app? Okay, I think it's on YouTube. Fine. Okay, great. Thanks, Sumit. Good evening, Anushka. So it's been quite some time that I've taken lecture for you guys. I hope everything is doing good. You're preparing amazingly well for your exams. Yes, Sarkar, same feel here. Okay, so there's Farre 2.0. So the last ditch response for us to kind of clear the university exam, right? So these lectures, I won't be concentrating much on concepts. The goal here is very simple. If you've not done your pathology well, this will be the way to write an exam, format an exam. If you've done pathology well, I want you to revise every day before the class, whatever topic it is. I'll be engaging you in the WhatsApp as well as in the Instagram channel. I'll tell you what to read for how many hours to read. Read that, and again, this will be useful for you to formulate the test, right? That's all, right? Okay, let's go. How many of you, your university exams are announced? Vaishnavi, first year you will have it separately, okay? This was second year who's going for the exam. If your university exams are announced, don't worry, don't panic. It's very simple, right? Exam has a very simple rule. The most easiest thing to pass in a university, in a classes exam, especially theory exam. Practical might sometimes be difficult. University exams are very simple, right? These are the golden rules of an exam. Please remember this always. If you know the answer in an exam, right? Write it crisp and concise. Don't keep on writing paragraphs, definitions. No one likes that. Crisp and concise if you know the answer. No one cares about the number of pages you write. If you don't know the answer, write story of whatever you want. Right? Whatever story you know, write from general pathology, general microbiology, whatever you want, right? But if you know the answer, be very crisp and concise, right? And then there are two sets of students, right? One are students with very good handwriting. How many of you here have good handwriting? They feel that they have good handwriting. If you have a good handwriting, write the exam point wise. Okay, it'll be very good to write the exam point wise, right? Vaishnavi, this for second year students. First year you have Dr. Pradeep taking class. Let's continue this class for now, fine? So write point wise, highlight the point, underline the point. If you don't have a good handwriting, right? Especially if people you think that I don't have a good handwriting, please go with flowcharts and also use capital letters, because when you use capital letters, the handwriting kind of appears good. We know that, I know, right? I'm a standing example for that. My handwriting is not good. If your handwriting is not good, use flowcharts and use capital letters. That kind of takes care of the problem, right? This is especially for presentation. Multiple colors really doesn't matter, right? Be it legible, point wise and easy so that it's comfortable. Fine, that's all. Okay, now let's go to long answer format, right? I'm sure you guys have a long answer question. There'll be clinical scenario given and there'll be like 3-4 questions under that. What's the pathogenesis, what's the differential diagnosis, how you diagnose, right? For long answer, the format is already created, which means they will be asking like, what is the pathogenesis of the disease, 2-3 marks. What is the differential diagnosis of the disease, 2 marks, right? It will be already there. So how do I present them? The goal in a long answer is to convince your examiner you have thought through the answer and not memorized few past year questions and solved it, right? That's very important. If you have thought through the answer, it's comfortable. It doesn't matter if you are writing it rightly or wrong. If your thinking process right, it gets a mark. That's how the university exams are scored, right? I want you to use this. Whatever question comes, you write a point, heading whatever you want, write data analysis or case history or whatever is comfortable with. Write the pointers. So the first 2-3 lines is going to come from the question itself, the age, the history, the lab finding, right? Then use either of this. Don't use both. If you feel that you don't know the right answer, use the term differential diagnosis. It's completely acceptable because doctors after finishing MBBS, MD, DM fellowship use the term differential diagnosis. Second year MBBS, if you use the term differential diagnosis, doesn't matter at all, right? So use the term differential diagnosis, and if you're not sure about it, if you're sure about, okay, this is the answer, right? Most probable diagnosis. Again, this is the way to communicate to a patient in future. That's why these words are very important, right? So the first 3 lines of long answer is already sorted, which is the case history, what is there in the question. Then most probable diagnosis. Then, like I said, the format is already there. The questions, whatever they ask, write them. Don't overdo them. Fine. Okay, I'll give you a few examples, Samantha. We'll see how to go through it. Fine. So now I'm going to show you few questions. I want you to comment on the same steps, data analysis. Tell me what are the important pointers there, and let's together come to a most probable diagnosis. All these are questions from renal pathology. Very, very simple and easy questions, right? Okay. Now tell me what are the data points or the history which is important in this patient. Don't jump to diagnosis. I don't want a diagnosis. I really don't care about a diagnosis. Everyone online here, comment. If you make a mistake, it's completely fine, so that in a real exam, you will not make a mistake. What are the important pointers here? 45 years, symptoms, perfect. Hey, others, comment, it's okay. Comment. 45-year, bilateral flank pain, family history, perfect, right? So here, like you guys commented, you're given lots of things for me here, right? One is 45 years and there's a family history. So by default, I am telling to the examiner, I am dealing with an elderly person presenting with a family history, autosomal dominant disorder. That's all. Second, bilateral. It's both the sides. Bilateral, symptom is early onset hypertension and a gross hematuria. Renal imaging shows multiple bilateral cysts, right? So these are the important points. Like I said, the first 3-4 lines are there in the question. Don't worry how to start it. Starting trouble is always there in the question, right? So let's present like this. Data analysis or case symptoms, whatever it is. Elderly, family history, I can add it to it because family history also is important because I'm going to tell it's a genetic disorder, right? Hypertension, early onset, bilateral lesion, hematuria. See, hematuria is not the classical finding of ADPKD. I am sure that you know the diagnosis of ADPKD, right? So tell the reason why there could be hematuria in patient with ADPKD. Because in a cystic kidney disease, is there an increased risk of infection and stones? Definitely. So this is an extra brownie point. If you're aiming for a distinction on us, tell them why it is. Because that's not a classical presentation. If it's a classical presentation like hypertension, you need to explain why. Hematuria is not a classical presentation of ADPKD. So write them why you have hematuria. Then investigation. Samantha, you asked me, right? So should I write investigation? It's very, very important. Put a separate heading. It adds to your depth of analysis. Investigation might include your ultrasonogram, lab investigation, whatever it is, right? Bilateral renal cyst seen. So the most probable diagnosis is ADPKD, right? This is how I want you guys to present. Any question, be it microbiology, pharmacology, medicine, surgery, ENT, this approach is very important because this is how I want you guys to see patients in real future. Don't jump to this and say, okay, it's a cystic kidney disease. Age, history, sometimes gender also might play a very important role, right? So all of them is important for us to come to a conclusion. Clear? Okay. Okay. We'll do the same exercise for 2-3 more questions. How many of you are in? Only few of you are commenting. I want everyone to comment here. Ready for the next question? Only if you say yes, I'm going to go to the next question. Ready? Same thing. I don't want the diagnosis. Let's comment on what are the important points and then you guys suggest me the diagnosis. Right? Right? Wrong, wrong. That's it. Fine. Okay. The next question. Tell me the important points. Just the important points. Three-year-old. Yes. Great. Anything else? 3-year-old is definitely important. Failure to thrive. Anushka, hematuria and ADPKD could be due to an renal calculi formation. Hepatomegaly, that's also important. Okay, Bob videos will come to the diagnosis soon. 3-year-old, abdomen distension, hepatomegaly, right? So can anyone tell me what could be the reason for abdomen distension? What could be the reason for abdomen distension? Can it be just the cyst? Could be, right? Or it could be fluid, anything. But most likely I have a follow-up thing here. Ultrasonogram shows cyst, right? Perfect. 3-year-old, you have abdomen distension, could be due to a fluid or could be due to a cyst in the kidney because I don't have any particular pointers there. Failure to thrive means the general condition of the baby is not doing good, right? And also there's hepatomegaly, right? Now, can anyone tell me what could be the probable diagnosis in this patient? Again, whatever comes to your mind does not matter. Right or wrong does not matter. Whatever comes to your mind. What's a probable diagnosis here? What do you think is a probable diagnosis here? ARPKD, that's all right. It's most likely in ARPKD. Fine. Samantha, I'm not against minimal chain disease because if it's a minimal chain disease, I would have expected a facial puffiness. That's not there. Second, I don't want an enlarged kidney in a minimal chain disease with cyst. That will not be there. So it's unlikely to be minimal chain disease. Most likely ARPKD. Can anyone tell me why is this important in an ARPKD? Again, if you give reason in the diagnosis, it gives you extra pointers. What is the reason for hepatomegaly in an ARPKD? Can I say ARPKD can also have hepatic cyst and also liver fibrosis kind of thing, right? You will have chance of hepatic cyst formation as well as hepatic fibrosis, right? So that could be the probable reason the patient is having an hepatomegaly, right? So how do I present this? Young age, that's important for me. If you want to write 3 years, more than happy, write 3 years. Abdomen swelling with liver enlargement. If you want, add most likely due to hepatic cyst. Again, you are giving reason why it is there. Even if your answer is wrong, your thought process is right, the examiner will definitely give you extra marks, right? An investigation shows renal cyst. Again, the most likely diagnosis is ARPKD. Probable diagnosis ARPKD, right? Good evening, Kamran. Fine. This is how I want you guys to present. Fine. Clear? Just now I said, Samantha, hepatomegaly most likely could be an hepatic cyst because ARPKD can have hepatic cyst, hepatic fibrosis, livers, and also a renal cyst. Fine. Okay. Paradox, not the right time. Come after 2 years, we'll definitely learn pathology in a best possible way. Fine. Okay. Now, like next possibility. Ready for the next question? I want more S's this time. Come on, let's be enthusiastic. I'm more excited about your exam. You should be excited about your exam than me. Let's start. Perfect. Okay. Again, the same thing, the same routine. Tell me what are the possibilities. Tell me only the important points. I don't want the answer, only the important points. "60-year-old, weight loss." Perfect. Anything else? Aged, flank pain, smoker. Perfect. Smoking. Perfect. Anything else? Solid renal mass, right? So again, I hope you are getting the flow, right? It's stepwise. Don't write CT scan first because no one is going to look at the CT scan first. Age is important, like you guys exactly said. Smoking history is important. Unexplained weight loss. Can I say unexplained weight loss most likely is pointing towards a cancer? Yes. Flank pain, hematuria, palpable mass. That's a classical triad of renal cell carcinoma. Abdomen mass, abdomen pain, and hematuria, right? Most of the time you may not see all three, but it's a classical triad, and CT confirms there's a solid mass, right? So how do we present? The same way. An elderly smoker, mass, pain, hematuria, weight loss, most likely in cancer. The reason why weight loss is given is, can I say all this could be a feature of benign tumor of kidney, like an angiomyolipoma? Possible? Possible. Mass is just a mass. It could be benign or malignant, right? For me, weight loss is something which is pointing towards a cancer and not pointing towards a benign condition, right? So that is also very important. Then investigation shows a solid renal mass. The most likely diagnosis is renal cell carcinoma, right? Again, like I said, other follow-up things, the template will already be there, right? Yes, Viper. Due to inflammatory mediators, you have weight loss. Perfect. Okay. Okay. Next question. Again, try this. This is very, very simple. Lokesh, all the very best. Come back after a couple of years. Once you finish second year, first year, I'll be taking pathology for you. Same template, same thing. Build a scenario. Try to solve it step by step. Great. One kudos for everyone here. In this patient, no one specified or many didn't specify this age. My only simple question is, nephritic syndrome, especially PSGN, most likely diagnosis. Is age important here or not important? Can a nephritic, your PSGN happen to me or a 50-year-old person? Can happen, right? Definitely can happen, right? So here I would say don't give the age because age is not that important in a nephritic syndrome because it can happen in anyone. Streptococci has a little bit more advantage in younger age, but doesn't matter. Streptococcal sore throat, streptococcal PSGN can happen in 55, 65, any person, right? It's an infection. Infection related glomerulonephritis can happen in any patient. If you are stressing, great, but it's not very important. Doesn't mean every information given the question is important. I want you to remove a little bit, right? It's more common, but this is not going to help me in diagnosis. PSGN can happen anywhere. Definitely a little bit more common in children, but that's That's not going to decide diagnosis. Minimal change disease, age decides diagnosis. Cancer, elderly decides diagnosis, right? So that's more important for me here, not much important, fine, perfect. Okay, now let's, I'll take, come to another question very soon, fine. Now here, patient has a sore throat, that is past history, okay? This is how you must have taken case scenarios in your medicine, surgery, OG, pediatrics, right? In your clinics. That's also important, the terms. Past history of sore throat, which again telling me it's a something happening for few weeks, right? And present history, hematuria, hypertension, and puffiness of face, right? Another question asked me, why do I have periorbital puffiness? Okay, question to everyone here. Periorbital puffiness is a feature of nephrotic syndrome or renal failure. Vaibhav, in case of nephritic syndrome, there's a rupture in the basement membrane, so there's a leak, so that's what results in hypertension. It's a feature of nephrotic syndrome or renal failure. It's a feature of renal failure, not just nephrotic syndrome. If kidney fails, you'll have swelling, that's all. Albumin also happens. If kidney fails, RA system will go for a toss. You will have undoubtedly edema, right? It's a feature of renal failure. PSGN can also cause renal failure, right? That's the reason nephrotic syndrome also can have it. Nephritic syndrome can also have it. You have an acute tubular necrosis, there also you can have this, right? It's not only a feature of nephrotic syndrome, it's a feature of kidney related problem. That's why, fine. Someone has asked some other question. Okay, how do I know past history? Because it's given here, right? 2 weeks ago, Samantha. That's how you say it's a past history, fine. Now, mild proteinuria and hematuria are the investigatory findings here. So I have the most probable diagnosis. Please use this term. Don't jump to the right answer, right? If I have a category, under that there are five or six things. Like if a classical case of minimal chain disease, don't write minimal chain disease. Nephrotic syndrome, most likely or probably minimal chain disease. Nephritic syndrome, probably RPGN. Because that again, if you're wrong in this will give you mark. Step by step. Always go step by step. That's a bit easier for you guys. Fine. Okay. Last thing for scenario. Then we'll go to the templates of short answers and we'll look at every single question on what is required. Fine. Okay. Let's go. Important pointers and your diagnosis. If it's something difficult, don't go away. It's fine. Make an attempt. You'll most likely get the right answer. Old chronic congestive failure, decreased urine output, past CHF. Okay, can anyone tell me what's the most probable diagnosis here? We got lots of information here. 70-year-old, history of congestive cardiac failure with rapid decline in urine output, fatigue and confusion. Blood test shows elevated BUN and such of acute kidney injury. Most probable diagnosis? Okay. So we have one diagnosis here, which is FSGS. Let's see if the right answer. Anyone else? ABC user. ABC user, put your name next time. No, I want your name. ABC is not good. When you say the right answer, name is more important for us, right? Pre-renal acute kidney injury. Okay. So again, renal failure. Okay. Now these are the three differential diagnoses we got, right? FSGS, very unlikely, because for me, for FSGS, I should have a classical symptom of nephrotic syndrome. When I do a blood test or urine test, I should have those findings. That's not the primary finding here. I have one creatinine ratio is increasing, right? Again, FSGS is chronic. Rapid decline is bit unlikely, Sarkar. So I won't think of an FSGS here, right? Because it won't have a rapid decline. It will be a very steady, slow decline here, right? Pre-renal AKI. Let's look at this and let's see if that could be the right answer, right? This question needs some explanation. It's not straight away, right? So for questions where I don't have the straight answer, I want you to explain in the data why it is the right answer, right? History is important for me. There's a rapid decline in the renal output or the urine output. That's the classical finding here. Now the explanation comes. The patient is a characteristic feature of congestive cardiac failure. In patient with congestive cardiac failure, can there be a reduced circulatory volume? Heart has failed. Ejection fraction will fail, right? There will be reduced circulatory volume. When there is reduced circulatory volume, can I have kind of a cardiogenic shock? Kind of that? Yes. I won't exactly call it a shock, but reduced circulatory volume, right? So like ABCC said, I could have a renal hypoperfusion. If the renal hypoperfusion happens, can it result in your AKI or ischemia to the kidney? Yes, it results in acute tubular necrosis ATN or an acute kidney injury AKI. Right? We have two types of ATN: nephrotoxic ATN and hypovolemic ATN. This is a classical example of hypovolemic ATN. Sometimes you would require this step-by-step explanation. Right? Again, don't use this for everything. I've got multiple cases here. Some of them are very straightforward. Some of them I need to tweak a little bit, past history, present history. Some of them might require explanation here. Right? Ischemic ATN and acute kidney injury is the right answer. The most probable diagnosis, if you write ATN, AKI is more than enough for me. But if you are very accurate, it's an ischemic variant of an ATN, acute tubular necrosis. Clear? Perfect. Okay, this is the first part of a long answer. The second part of a long answer, you need not worry. Already there'll be a template given. What's the diagnosis? Based on that, write whatever questions they are asking. Like 3 marks, 4 marks, 2 marks will be divided based on that writer, right? Now let's go to a short answer format. This format is for renal glomerulonephritis. This format will change for everything. Fine. Okay. So etiopathogenesis, that's how we are going to start for most of the disease. It will be more or less same. Clinical features. Don't read clinical features for every disease. If I talk, let's say, minimal chain disease, what type of disease it is? Nephritic, nephrotic, acute renal failure, chronic renal failure, minimal change. What do you think it is? Nephrotic syndrome, right? So just remember that. That's more than enough. Fine. That's a classical symptom of AKI, Samantha. Fine. That's all. So need not revise every time. What are the features of nephrotic syndrome? You already know that. You just take and put it there. PSGN, nephritic, nephrotic, acute or chronic. Could be nephritic, right? IgA nephropathy, nephritic, nephrotic, acute or chronic. Nephritic, right? So go with the disease. You already know that. So clinical features, don't read for most of the diseases. You have a template. Go with the template. That's much easier for you. Just mix and match, right? So how do I remember this? Robbins is an amazing book. You can learn the concepts. At the final, you can compile everything also. There's a table from Robbins. I just added one more thing. That's all. Nephritic syndrome. For any disease with nephritic syndrome, these are the manifestation. So when I say manifestation, it includes the clinical features as well as it includes the lab findings. Both of them are here, right? Hematuria, classical symptom. Variable proteinuria might be a lab finding. Oliguria could be a symptom or a lab finding. Azotemia. Whenever I use the term azotemia, it means increase in the bun creatinine, right? Blood urea nitrogen and creatinine is azotemia, which means renal failure. Hypertension symptom, edema symptom. Whenever you see nephritic syndrome, all these are possibilities, write them. Whenever you see nephrotic syndrome, these are the possibilities. Again, a lab finding, and you can say present with an edema or a facial puffiness as a symptom. Done, sorted. RPGN, rapidly progressive glomerulonephritis. It's a very acute renal failure. The onset is very important here. The rapid onset is very important here to fill the blanks, right? Chronic kidney disease, azotemia for months to years. The question says the patient is having an elevated creatinine for 2-3 years, slowly decline in renal function, chronic kidney disease. Can I say FSGS can be an example of chronic kidney disease? Undoubtedly, right? Could be. And acute renal failure, it's lost or reduced renal output, azotemia, but for a very short term, in days. That's how acute renal failure is going to manifest. These are the most common presentations which can come in renal chapter. In addition to this, right, we will have by default infections. Can you write 2-3 lines for history of infection? Let's say acute pyelonephritis. Can anyone tell me history of acute pyelonephritis? Go back to the channel, Mohit. You'll have the questions there. ABC, you said when I say variable, it could be 1 gram, it could be 0.5 gram, it could be 1.5 gram, it could be 2 gram. That's variable proteinuria. It's not always 1, not always 2. It varies. Symptoms, right? I'll have a history of UTI, perfect. Chills, rigors, possible. Flank pain, definitely possible, right? Tenderness in the flank area, definitely possible. You can easily write it, right? So these are outliers. If you have a history, if you have a question for that, you can easily write it, right? That's all, right? So those are the only things required here. And if you want to know the lab findings of pyelonephritis in the urine examination, WBC cast. You'll have WBCs, you'll have hematuria you will have, right? So you can easily write the clinical lab examination if you know these syndromes thing. Just before the exam, read that table alone. You can write for any renal related disease few things. Any disease in any subject, categorize them: infection, inflammatory, neoplastic. If you know, you can write the symptoms. That's all. Fine. Then the template is simple: microscopy, immunofluorescence, electron microscopy, management. Please don't stop with this. Don't miss this, because management is something which, though you won't know much about it, but a heading is worthwhile. If you talk about a PSGN, if you don't write at least a word, if you don't know anything, no, use conservative management, enough. But some word to conclude. I had a starting point of etiology. I need a concluding point of management. Because pharmacology is done, you will definitely know. You will definitely know how to treat an acute renal failure, right? Diuretics. If you want, write it. If you don't know, leave it. But at least something. Conservative management, please mention a term, because that gives wholeness to the question. Fine. Okay. Now, with the same thing, we're going to go for every disease. Whatever disease is required for you, let's go in quickly. I want your guys' support and answer whenever I ask a question. Fine. Okay, let's start. PSGN. What's the etiopathogenesis? Everyone, one by one. Etiopathogenesis. Etiology is simple. You can have a simple URI. It could be an URI or a skin infection. You know that there is nephrotoxic stain both in the throat as well as in my skin. This results in the planted antigen in your glomerulus. So to this planted antigen in the glomerulus, your immune system is going to have a reaction. There'll be an immune reaction. When there's an immune reaction to this, that will damage the glomerulus and it will cause hematuria. That's the classical etiopathogenesis, right? Like I said, I am drawing it horizontally. If your handwriting is not good, write vertically. Half a page is sorted, right? And say there'll be a timeline for sure, right? There'll be a lag time here. Lag time is very, very important here for diagnosis. There'll be a classical hematuria, fine, okay? And here you'll have a lag time between the onset of infection and the hematuria. There'll be a lag time. There's a classical for PSGN, fine. Clinical features: PSGN, nephritic or nephrotic? Nephritic, that's all. So you can easily write a past history of UTA or a URI or skin infection, right? Then you can easily say that this patient had an hematuria, cola colored urine, facial puffiness if you want to add it, presented with and on examination had a hypertension, urine examination showed proteinuria. All things you can write, right? Easily, right? Let's come to microscopy. I'm not going into the hardcore PSGN. PSGN is acute or chronic? It's acute, right? Everyone here will accept that PSG is an acute disease post streptococcal, right? It's simple. The first finding, a very non-specific finding, larger glomeruli. The glomeruli will become large in PSG. Second finding, since it's acute, obviously you should have neutrophils inside your glomerular capillaries, or you can write capillaries. This is what we must have read as an endocapillary hypercellularity. You can add past history in the clinical features. If you want, you can add it, right? Flea bitten will not happen here. It's an different things, right? You'll have neutrophils inside the capillaries and you call it endocapillary hypercellularity. Fine, perfect. Okay, these are two classical findings. That's more than enough for me, right? Generally, it is always good to have a diagrammatic representation. You need not use eosin and hematoxylin. Anything is fine, but if you're comfortable with eosin and hematoxylin, and God forbid the pencil does not break in the exam, everything goes good, right? Just draw a tiny thing, representation, right? When you draw a glomeruli, no one cares for every capillary loop there, right? Just draw a couple of them, enlarged, couple of them enlarged, right? And put two WBCs there and mark it. Endocapillary hypercellularity, as simple as that, right? Again, it's the representation. Is it beautiful glomeruli? No, because this glomeruli is not going to function, right? Just representation of what you believe, what you know. That's more than enough, right? If I have mesangial problem, put a capillary and mark a big mesangium and say there's a mesangial problem, right? Again, it's just representation, which makes a huge way, because pictures any day speak better than words, fine? Next, immunofluorescence. In immunofluorescence, there are two things which any examiner looks for: whether you are writing linear granular properly. Second is, what are the antibodies which will be present? There are multiple things, at least the classical ones are required. If I'm talking about an IgA nephropathy, what antibody will I look for? If I'm talking about IgA nephropathy, what antibody do I look for? I at least look for IgA. If you have answered C3, C1Q, doesn't matter. I at least require IgA for IgA nephropathy. One is enough for me, right? So here, when I say immunofluorescence, what is important for me here is, you will have granular pattern. Again, this also need not memorize. There's only one glomerulonephritis, which is linear pattern. What is that? Which is Good-Pasha syndrome. Rest everything is granular, right? You have granular pattern of, like some of you said, I can have IgM, I can have IgG, I can have C3. C3 is very, very important. So whenever you write C3, the next finding should be serum C3 will be reduced. That's also a very, very important finding in PSGN, right? Reduce serum C3, IgG, IgM and C3 are classical for your PSGN. For PSGN, it's IgG, IgM and C3, Samantha. Okay, perfect. Electron microscopy, subepithelial, subendothelial or intramembranous? It is undoubtedly subepithelial, right? If you want, you can write classically subepithelial humps. Hump-like deposit, that's a classical finding for a PSGN, right? Subepithelial humps is a classical finding, fine. There are few extra pointers you can write if you know this collagen starry appearance or a lumpy bumpy deposit. These are extra pointers. If you want, you can write, right? So this subepithelial deposit can easily be represented by the help of a diagram, fine. So you draw this. This is my basement membrane. Put a foot process here and put a big deposit here and draw an endothelium here, right? If you want, mark this as a subepithelial deposit. Okay, one, it won't take time to draw this. There's no neatness here required. It's a location required. And they'll say, okay, this guy or girl is representative to diagram. That's more than enough, right? Management. Okay. Now tell me, what is the problem in PSGN? The bacteria or the kidney? The primary problem is bacteria, right? So I do a conservative management, observe the patient. If the patient is a very acute failure, I take care of that. Otherwise, I'm just going to have a very conservative management, right? So here it's going to be observation and conservative management based on the treatment, based on the stage. If the patient is having a very acute failure, can I say that PSGN can become RPGN? Is that possible? It's possible, right? That time I might require dialysis. Otherwise, observe, it will automatically come back. If the patient is having very high hypertension, give that. Give antihypertensives, control that, right? That's enough, right? So just one word. Again, last one is to complete. You need not be right. That's the thank you slide they put in every presentation, right? Which has no sense and no one is ever going to see that. It's like that. I need that thank you slide. I need that management there. That's all, right? So one page, everything is sorted. The same template we are going to do for every disease, whatever is required. Fine. Perfect. Great. Tell me. MGN is membranous glomerulonephritis. Etiology? In etiopathogenesis, I have one primary. Primary is your antibodies against your PLA2R, phospholipase A2 receptor. I have secondary, which could be against drugs, which could be against hepatitis. Hepatitis can cause it, which could be SLE related. SLE can cause it, right? There are multiple things, but the primary one is more important for me, is antibody against PLA2R, right? Perfect. Now I know the etiology. Pathogenesis, I'm not writing here. I'm going to hook it up to different place. When I say it's an antibody against to an antigen, that's a receptor. Can I say it's kind of type 2 hypersensitivity? Yes. When you revise like that. That's all. So write that. That's more than enough, because every pathogenesis you read in systemic pathology and hematology is based on general pathology. You pinpoint. If it's a 5-mark question, don't elaborate. If it's a 10-mark question, elaborate. You need to cover pages. That's our ultimate goal, right? Elaborate if it's a 10-mark question. If it's a 5-mark question, these 5-6 headings are more than enough for me, right? PLA2R, type 2 hypersensitivity, antigen antibody reaction, destruction. That's all. Membranous glomerulonephritis, predominantly nephrotic syndrome. Some amount can be nephritic, does not matter for us, right? Membranous glomerulonephritis, what could be the classical microscopic finding? What could be a classical microscopic finding of membranous glomerulonephritis? It's nothing but a very or increase in the capillary thickness. That's a classical symptom of membranous glomerulonephritis. Capillary thickness will be very increased, right? I won't call it hyperplasia IBS user. It will be a thick capillary. That's membranous glomerulonephritis, right? Because of this, there's one extra point here. Silver stain might help here. In silver stain, I have a finding called as spike and dome appearance. That's a classical finding seen in silver stain. Fine. So how do I have a representative image of this, right? So just put a round for a glomeruli. Okay. Put a tiny thin capillary, maybe draw a couple of capillaries as thin, right? And draw a line here and draw thick capillaries here. See, ultimately I have to tell the teacher I know it, that's all. Mark this membranous glomerulonephritis area, mark this normal glomerulus. So you're exactly telling them I know how normal looks, at the same time I know how abnormal looks. This takes like 10-15 seconds to draw. Enough. Need not be beautiful. None of the diagrams need to be beautiful. They have to be descriptive. That's more than enough for me. Fine. Okay. Immunofluorescence. Linear or granular? Everything apart from good pasture is granular. So that is sorted. You won't get confused between linear and granular, right? It's type 2 hypersensitivity. Can anyone tell me what's the most common antibody? IgG or IgM? It is IgG, right? Every type 2 hypersensitivity, the most common is IgG. That's why warm autoimmune hemolytic anemia is common, IgG related, right? Everything has to be IgG. So don't miss this. I want this. Extra, if you want, write C3, C1q, does not matter for me. This is minimum requirement here. That's enough for me. Electron microscopy, subepithelial, subendothelial, intramembranous. So it's also subepithelial. The only difference between this and PSGN is the subepithelial, but they are uniform. They are not hump-like, they are uniform. So how do I draw a uniform deposit is? I draw a line, you draw an endothelium here. It's a uniform deposit. It means I'll have a deposit here, I'll have a deposit here, I'll have a deposit here. It'll be uniform across every subepithelial space. I'll have a deposit. That's how it is, right? Again, treatment. Treat the primary etiology. Since it's antibody related, steroids will play a very important role. And then again, supportive management. If the patient is having a very acute damage, I take care of the acute damage first, then I'll take care of the rest. That is going to be there. Every autoimmune disorder, you know the treatment. It's going to be the same thing. Hump means you have an oxus hump. It's a sudden jump. That's a hump. Uniform is throughout. Okay. Perfect. The next one. Tell me. You guys are going to fill. Etiopathogens of ARPKD. Etiology can be anything, right? In any acute glomerulonephritis, if it's acute and if it's very heightened damage, it results in ARPKD, right? So you can write any medical renal disease, or you can write any glomerulonephritis, whatever is comfortable for you. When it's very severe, this results in a rupture of membrane. When it results in a rupture of GBM, it results in the formation of crescents. Crescents are formed. The formed crescents will compress the glomeruli and it will destroy it, right? So now I have to say what are crescents made of. That also you write here. Crescents are made of your parietal epithelial cells, WBCs, your fibrin, and your macrophages. Again, if you write this in a straight line, it will fill half of your page. Easily, it will fill half of your page. Parietal cells are more important. Fibrin, WBC, macrophage will definitely be there by default. Clinical features, rapid onset. On a pre-existing disease can happen, right? It's a very sudden progression of an acute renal failure. That's a clinical feature of ARPKD, right? Microscopy. What is in microscopy? That's the name. The other name of ARPKD is crescents. You're going to see crescents. Okay. Again, the teacher should know what you understand or what you know by the term crescent, right? So a representative diagram. Fine. Put a glomeruli here, compress glomeruli here, and put a crescent here, and have all these cells. Maybe mark in a different color. Lots of cellular population here, which is compressing the glomeruli, and mark this as crescents. So the crescent is going to compress the glomeruli. If you want, draw one more diagram as well, right? It's nothing but all the collection of the above cells are compressing it. A representative diagram, that's more than enough. That's what I see in light microscopy, right? Immunofluorescence is the basis of classification of ARPKD. How many classifications are there, or how many classes are there? 1, 2, 3, 4, 5 in RPGN. We have 3 classifications, right? So we have type 1, 2, and 3 based on linear, granular, or posse-immune, right? So write that classification. Type 1, linear immunofluorescence, you go for Goodpasture syndrome, right? Type 2, you have granular immunofluorescence. I'm just writing here rest of all the glomerulonephritis, which includes almost everything: IgA nephropathy, PSGN, MGN, lupus, MPGN, everything goes there, right? Type 3 is important. See, this is where most of the examiners will be looking for, because type 1, type 2, you know already. Type 3 is very unique because it is posse-immune. What comes under type 3? Which means no immunofluorescence. What comes under type 3? You'll have your vasculitis, right? Right, your vaginous or your microscopic polyangiitis. The ANCA-mediated vasculitis, that's what comes under type 3, fine? That's a classification there, right? Electron microscopy. What's a classical finding in RPGN? What electron microscopic finding? RPGN, electron microscopic finding. Break in the basement membrane. That's where we started, right? The break or the ruptured GBM is the one which is going to cause all the problem, the rupture. That's what you see in electron microscopy, breaks in GBM. Management, immediate hemodialysis. I don't care what is the cause of RPGN, you have to do an immediate hemodialysis. Once you do an immediate hemodialysis, later on we can see what's a primary cause, will it be recurring or it's a one-time event, we'll take care of that, right? Okay, so this is what I want you to do for every exam. Every question in renal, we'll have template like this for every disease throughout the body. See, because this gives you, I at least know what to write, 5 headings. Now 5-mark question, you write 5 headings and you fill 1-2 line in every heading. That comes for 1 page, 1 or 2 representative diagrams. That's more than enough. It's a good examiner, they'll give you 4 marks. Strict, so-called strict examiner will give you 3 marks. No one will be able to give less than 2 marks for this, right? Your goal of P will be sorted with this, a template, a clear understanding. See, the most important thing is I've gone for paper corrections. Whenever they don't have any teacher, they may call me because I am not attached to a medical college, just as a supplementary person. The first thing most of the people look in the exam paper is it legible? Is it clean? That's all. Because you will have close to 15 minutes to correct an entire paper. That's the only time available. No one is going to read. Headings there, okay, decent. 2-3 points there, tick, 4-5 marks, that's all. That's how the paper correction goes. Don't worry, no one reads. They'll have a key, this is what to look for, but no one looks for that. I look, if RPGN has these 3 things, I know that you know stuff. I won't even read the rest. Click, tick. I'm going to look for only this. This I look for, this I look for, this I look for, I look for this, because hemodialysis is very, very important, right? That happens in malignant hypertension, Samantha, okay? So a template gives a very, very good success rate. So stick to that for an university exam, fine? Minimal chain disease, fill the template. Etiopathogenesis, what could be etiology of minimal chain disease? Anything which comes to your mind. Minimal chain disease, you can write anything, right? Could be a vaccine, commonly, or a viral infection, commonly, or drugs. But this, we don't know the exact pathogenesis, so we are writing many etiology. What happens is it results in an effaced food process. Okay, in a minimal chain disease, the clinical symptoms are classical nephrotic syndrome. Here, age matters. A child with classical finding, urine examination shows classical finding, I think of a minimal chain disease. That's what it is. Microscopy. What do you really see in light microscopy? The most important thing, what I look for in a minimal chain disease is, start with this, no? Ghosh, if the question is write the lab diagnosis, start with the lab diagnosis. Let's take this disease, no? Minimal chain disease, lab diagnosis simple. The patient comes with a facial puffiness, presentation. Lab, I'll have massive proteinuria, albuminuria, right lipiduria. Microscopy, you will see oval fat bodies, lipid. Blood examination, you will see less albumin. If you have renal failure, you will have high creatinine, high blood urea nitrogen, right? You can write. It's very simple to write. Okay. Based on it, you please modify it. Think for couple of seconds, 10-20 seconds, you will know what to write, right? Normal glomerulus, that's most important I look for. Again, if you want to score more, like you guys said, I'll look for the other term, lipoid nephrosis, which means I'll have your fat in your proximal convoluted tubule, right? I'll have lipid in proximal convoluted tubule. I'll look for this. Immunofluorescence will be negative. Yes, Samantha, this is seen in children. Okay. Electron microscopy is the most important here. It's effaced food process. See, I cannot draw a normal glomeruli here and explain I have understood it. It's normal. Immunofluorescence is negative. I cannot draw anything here, right? So effaced food process where I can draw. So draw a normal electron microscopic image with a food process, and then say it's normal, and then efface it, destroy it, say it's effaced. Because if I need some representative diagram, this is the only thing I can do here, right? It will not again take more time. Normal to efface, that's all, right? Because there's no immunoglobulin involved here, so it's negative, right? Management, you guys know the management, it's steroids. Worst case scenario, if you don't know any management, put steroids there. Not the right way, but something anti-inflammatory will be a part and parcel of almost every treatment. And supportive management. These two terms are used to escape. That's all. If you don't know anything regarding management, write them. Fine. Okay, let's go to IgA nephropathy. Etiopathogenesis of IgA nephropathy. You guys have read IgA nephropathy, right? I have two things here. One, it could be a defective IgA. That's one of the etiopathogenesis, or primary. Secondary is for me liver failure. No, that is a trigger. Another question, UTI is the reason, URI is the reason. That's not the etiology, right? A liver failure or a defective IgA in this patient when you have a mucosal inflammation. You can write URI, UTI, diarrhea, anything. Any mucosal inflammation here, you will have an excess of IgA. This excess of IgA will get deposited in the mesangium and cause mesangial injury. Just write, it'll cause mesangial injury, that's all. Okay. The primary problem is defect in IgA and or liver failure, because in liver failure IgA cannot be removed, that's all. Defective IgA or liver failure. Like Shreya said, if you can write that O-link glycan defects, amazing. But will an examiner look that deep? I don't know. But that's how it is. Defective IgA and liver failure, fine. Samantha, if they are asking only microscopic thing, then you have to elaborate on the microscopy. Write this microscopy, and maybe if you feel it's very less, write the reason why it happened. So it'll make much more sense. Draw a diagram better. It'll make much more sense. Fine. The most important thing I look for in clinical examination in IgA nephropathy is the recurrence, right? If you want to score more, the other name, the Burgess disease. A recurrent hematuria, a recurrent symptoms of nephritic syndrome is a classical finding seen in IgA nephropathy, right? Microscopy. It's a problem in the endocapillary or the mesangium. It's mesangium. Two things here. The mesangium widens, and also there will be hypercellularity. Okay. Mesangial widening and hypercellularity will be a classical finding seen in case of an IgA nephropathy. Like Weber said, yes, adult age will definitely help me, right? Mesangium requires a representation, because you need to understand, you need to convey to the examiner, I really know what is mesangium, right? So again, divide into two. For kidney, dividing into two makes easy sense. So you can show this is normal, this is abnormal, right? So draw. At the same time, it will conserve space also. I need not keep on drawing the abnormal things in multiple places, right? Normal, and maybe use a different color and say mesangium. Okay. And here, put again capillaries, use appropriate colors, and mesangium. There are two things here. One, mesangium has become bigger. At the same time, the mesangiums will have more cells as well. Put cells here. Okay. It's both mesangial expansion and hypercellularity. Yes, Srijit, I just gave a history of nephritic syndrome. You add on whatever else is required. Fine. So it's a template. You already know more than this. My only goal here in the Farre series is to how to convey whatever you know. Because if you keep on writing everything, you will miss these headings. I want in your exam sheet to have these headings. If it has, amazing. That's more than enough for us. Fine. Immunofluorescence. Deposit. It's mesangial deposits. It will be mesangial deposit of IgA and C3. But if you write IgA, that's more than enough for me. Extra brownie points for C3. That's all. Fine. IgA mesangium, good enough. Electron microscopy, again, deposit in the mesangium. Electron dense deposits in the mesangium, that's classical. Fine. Okay, that's most difficult thing here, right? Samantha, it's a problem in the mesangium, that's why it widens. Before next class, I'll tell you what I'm going to talk, and in the WhatsApp group as well as in the Instagram channel, I'll give you time and topics on how to read it, right? Like this question, this much amount of time, read it. Just go through the notes once again. So this will be much easier and a revision session for you. Okay, we have already read all of them. Here I am not going to explain again the exact concepts. It's not worthwhile for you in the last 1 month of the exam, right? That's why. Fine. Management, here again, symptomatic management, conservative management. If it progresses to chronic renal failure, okay, it might require a renal transplant, because there's something which can go into a chronic renal failure which might require a renal transplant by default. Fine. The outcome, the prognosis also we are writing about it. Fine. That ends with the management. Okay, representative images, no neat images, neat somewhat representative is more than enough, right? Last of it, FSGS. Tell me, etiology. There are two different etiologies for FSGS. We call it again primary and secondary, right? Here I have primary or your genetic related. Here you can write your mutation in nephrin podosin, the nephrin mutation, the congenital nephrotic syndrome type 1, podosin mutation, the congenital nephrotic syndrome type 2, right? These are the two common things at least we expect, right? And secondary. Secondary could be any recurrent glomerulonephritis, right? That's important. Only when it's recurrent, it becomes chronic. Minimal chain disease will not become FSGS. It has to be recurrent, it becomes chronic, or like Sarkar said, it could be a renal ablation. You remove a kidney due to something, other kidneys removed due to some pathogenesis, this kidney can have it, right? FSGS can also be seen in diabetes, hypertension. Okay, anything chronic recurrent damage to the glomerulus, end stages FSGS. Okay, this is the most common type of nephrotic syndrome. If you want, you can write mostly seen in adults, classical symptom of nephrotic syndrome, and also chronic renal failure. That which means you can easily write in the investigation tab. There'll be lots and lots of elevated creatinine, elevated urea nitrogen. That's classically will be present in FSGS patient. Right? Microscopy. What's a microscopic finding? That's a name. You'll have focal and segmental sclerosis. Write the name itself. That's all. It's FSGS. You'll have focal and segmental glomerulosclerosis. Okay. This extent of sclerosis might vary. If it's a very early onset, maybe 1-2%. If it's very advanced onset, it may be 80-90% also. So how do I draw it? Again, it's simple. Put a line, normal glomerulus. Sclerosis is the easiest way to draw. Sclerosed glomerulus, maybe put 1 or 2 loops here and there. Fine, that's all. It's normal, it's sclerosed. Okay, it's very simple if you compare, and it's easy for an examiner to see, okay, this person knows what they're looking for. Pictures are very attractive. It need not be neat pictures. If you don't have a clean neat handwriting, don't worry. It's always a myth that only when you write neatly you'll get marks. Not at all. If you write legibly, if they're not able to read, they can't read. That's a different thing. That's why I said use capital letters, use flow charts, neat representative diagrams, you will definitely get marks. Fine. Immunofluorescence, again, it's based on the disease. It's most likely granular. IgG and C3, write it. Based on the disease, it might vary a lot. IgG is important because all of them are chronic. None of them will be acute. IgM can also be there, but IgG, C3 will be there. Granular positivity across the thing. Fine. Electron microscopy, again, it's based on the disease. You can write based on etiology. I will see the fibrotic thing, but based on the etiology, wherever it's getting deposited, I'll have it. Fine. Management is based on the stage of CKD. Okay, because chronic kidney disease, it's based on the stage of CKD, but definitely you need renal replacement therapy. Use this term. Renal replacement therapy. What are the renal replacement therapy, you know? Anyone? FSGS treatment is undoubtedly renal replacement. I'm going to replace the kidney by something else, which might be dialysis or a transplant. For anything which I'm not able to treat, it has to be renal replacement therapy, either via hemodialysis or via renal transplant. That's a treatment for FSGS, fine. So those are my simple glomerulonephritis, right? Let's go to acute tubular necrosis. That's your AKI, which is the last case what we saw, fine. Can anyone tell me the classification of AKI? You guys told me when I display the question as well. There are two important risk factors of AKI. One is obviously your toxin related AKI, other one is ischemic AKI, right? Which is nothing but just ischemia or hypovolemia, which is going to cause acute kidney injury or an acute tubular necrosis, right? So the most common by default is ischemic ATN. And obviously, I also have toxin related ATN, toxin related acute kidney injury or an acute tubular necrosis, right? It's simple ischemia. You guys know the template of an ischemia. If it's a long answer, write whatever you read in the first chapter, right? There'll be loss of the microvilli, there'll be vacuolations in the kidney, there'll be clear change, necrosis, everything you can write, right? But if it's just a 5-mark question, need not write in depth about it. Just know that, okay, I'm having a damage here. Because of the damage, you're going to have accumulation. That's all, fine. Ischemic ATN generally will be discontinuous. Okay, this is a classical finding, will be intermittent or discontinuous damage will be there in the nephron. Toxic ATN generally will be an continuous damage in the nephron. When I say continuous damage, entire PCT or a loop of NL will be affected. But in ischemic, patchy affection will be there, right? And the pathogens for ischemic ATN, it's based on ischemic ATN only, right? So because of ischemia, there's a tubular damage. Because of ischemia, again you'll have overactivation of RAAS. When RAAS is getting overactivated, that will cause further vasoconstriction. That will cause further ischemia. That's a vicious cycle which keeps on happening, right? This tubular damage might give multiple things for me, right? Because of the tubular damage, I am going to end up in having a difficulty. The tubules, dead cells can go and block the entire tubule, right? The sloughed off cells can block the tubule, which will definitely by default result in lowering the urine output, right? Tubular damage can also leak the urine, which will increase the interstitial pressure. When it increases the interstitial pressure, and this also by default will ultimately result in low urine output or reduced urine output, fine. Ultimately is going to reduce the GFR, which is going to reduce the urine output, fine. Samantha, yes, you can definitely add the Columbia classification for FSGS. I just gave you a simple template. Columbia classification you can add. You can say that collapsing variant of FSGS is there. Also, you can put that in the microscope, fine. Ghosh, you are asking about ATN. If the question is only on the etiopathogenesis of ATN, write the etiopathogenesis in detail. Now I can easily expand. See, it's ischemia related. Can I say cardiogenic shock can cause ischemia? Yes. Trauma, hypovolemic shock can cause ischemia? Yes. So write that. So when it's only etiopathogenesis, you say that etiology, these are the chances where I can have ischemic ATN. Toxin, elaborate the toxin. There is carbon tetrachloride is a toxin, myoglobin is a toxin, hemoglobin is a toxin, multiple myeloma is a toxin, right? Radio contrast dye is a toxin. All these can cause toxin related ATI, right? So based on the depth of question, if it's only acute tubular necrosis, it doesn't make sense for you to write everything regarding the etiology. I have to restrict myself because writing this for 3 pages and missing 2 questions doesn't make sense. How much ever you write, maximum mark for this question is 5. They'll give you maximum 4, right? So based on the question, if you want to shrink this, shrink it. If you want to elaborate this, elaborate it. Fine. Okay, Ghosh. Hi, Naman. Clinical features is acute renal failure, which is reduced urine output, increased blood urea, nitrogen, and creatinine. Microscopy, classical finding in microscopy is you'll have, you'll have classically damage to the tubules, right? I'll answer your question, Krishnamurthy. Fine. You'll have tubular necrosis. When you have tubular necrosis here, you know that it's a classical example of coagulative necrosis with maintaining the architecture. Fine. Naman, मेरा हिंदी थोड़ा खराब है. Okay, this is the only thing I'm talking in Hindi. Fine. So हिंदी में अच्छा फ्लो नहीं आते हैं. So this इसके लिए मैं अंग्रेजी से बोल सकता हूँ. आपके लिए any doubt है? Tell me in Hindi. I'll try to reply in English or maybe in broken Hindi. Fine. Yes, perfect. You can write everything. Muddy brown cast line, you can add it in microscopy or you can add that in investigation. Fine. So here, if I want to representatively give a slide, okay, I put a normal tubule with nuclei, okay, and I put a destroyed tubule without nuclei, completely pink color tubule without nuclei. Fine. All these classical things you can draw. Fine. So you guys know a lot. That's the problem mostly in exam. You don't know where to stop. I'm just telling you where to stop. Because knowing a lot is good for life, but unfortunately not good for exam. You keep on writing, you don't know how to structure a question, you don't know how to present it, right? Our goal is to learn how to present it. Fine. In addition, microscopy of the urine examination, you can write the muddy brown cast. If you have brown color sketch pen with you, draw it, brown color cast, that's all. That will definitely be seen, right? Management. How do you manage ATN? Any acute kidney injury, the management is going to be fluids. It's going to be fluids based on the stage. I'll treat it, right? It's completely gone. Here also I would require an immediate hemodialysis to take care of that. Fine. Okay. That's a simple thing for ATN. Someone asked me, Krishnamurthy, right? Krishnamurthy, if only a microscopy is asked in an exam, right? What do I do? Like I said, no. If it's only a microscopy, start with microscopy. You're going to say there's going to be coagulative necrosis. I can go in two directions. Either I can tell why there is a coagulative necrosis because of ischemia related. You can write in brackets. There's necrosis here in the tubules because of ischemia related. That's gone. Fine. Okay. Next, I can also add to that. See, it's because of this ischemia related damage, I am having loss of the tubular function, which is resulting in oliguria. You can add that. And you can add whatever you want. Whatever the question is asking, change based on that. If they are asking this, start from microscopy, link to the etiopathogenesis, link little bit to the management, but always keep this. Even it's microscopy, write a word on management. Fine. You can definitely draw the cast, Samantha. Put a field here, brown color, muddy brown cast will be elongated things. Most of the cast will be elongated. And in the background, put a little bit of squamous epithelium, some urothelial cells here in the background. So the cast will be elongated things. Fine. You can definitely, Samantha. Clinical features of every 18 is as like an acute kidney injury, right? That's what I put in the initial table. Read the table, keep it as a template, mix and match wherever you want. Fine. Okay. Now let's go to renal tumors. Whenever you are writing cancers, a question on cancer, I want you to change one term. Don't write etiology. Always it's better to use term risk factors, because most of the time cancers, some do have etiology, but most of the time risk factor is a better terminology than having cancers. Fine. Can anyone tell me what are the risk factors for renal cell carcinoma? We saw a question. That's the most common risk factor. Smoking. Smoking is undoubtedly the most common risk factor for renal cell carcinoma, right? By default, right? In addition to that, asbestos exposure can happen by default. Obesity. I'm sure we know that benzene, benzidines, that petroleum products can cause. Heavy metals can cause. Sometimes an acquired cystic disease can cause. Tubular, some syndromes can cause, right? Hypertension by default is 1. Samantha, you can use definitely color pencil. Okay. Obesity can cause. Obesity is a risk factor, right? Petroleum products is a risk factor. Okay. Acquired cystic disease is a risk factor. Not any cystic disease, only an acquired cystic disease, which is secondary to hemodialysis, can happen, can increase the risk of papillary renal cell carcinoma. Estrogen therapy can definitely increase hyperestrogenism, right? These are sporadic. Most of the cancers will also have syndrome. Take colon cancer, I have sporadic, I have syndromic. Take breast cancer, you have sporadic, you have syndromic. Please include this in the template. If it's a question on cancer, it has to be risk factors, which most likely sporadic etiology. It is syndromic. Please don't ignore syndromes, because syndromes are very, very important, and most of the cancers from head to foot have syndromic association, at the same time sporadic association also, right? All these are classical syndromes. VHL, the genus von Hippel-Lindau gene classically increase the risk of clear cell RCC. If you know the subtype, write it. Otherwise, just name them, right? Second thing has everything in the name. Hereditary leiomyomatosis renal cell carcinoma syndrome. That's how it is, right? Here I have a gene called as fumarate hydratase. It's FHG. It's fumarate hydratase, where you'll have leiomyomas multiple all over, and you'll have a papillary renal cell carcinoma here. Okay. Then I have a variant of hereditary papillary carcinoma, right? Here the gene involved is MET on proto-oncogene. Okay. As the name says, you'll have multiple papillary carcinomas in the kidney. Birt-Hogg-Dubé syndrome. The gene is very easy to remember here. BHD. Birt-Hogg-Dubé gene. This codes for a protein. Remember the protein because it helps in a way called as folliculin. Where do we have follicles apart from ovary in the body? We can have follicles in your skin. Skin has follicles, right? So this syndrome will have skin tumors in addition to your renal tumors, right? I can have renal tumors of any etiology. You'll have renal cancers plus skin tumors. This can have chromophobe, this can have clear cell, this can have papillary of any etiology, right? So the term follicle helps you to extrapolate the other things as well, right? 4 syndromes, 4 random etiology, it's more than enough. That's enough for anything for etiology. Clinical features has a classical triad. The triad is renal, or it's not exactly renal mass, abdomen mass. On palpation, it's very difficult to tell me it's renal. Flank or an abdomen mass is more than enough. Could be a flank mass or an abdomen mass, hematuria, and abdomen pain. This is a classical triad of RCC. Most of the time, I won't see the triad. Sometimes I will see the triad, right? These are triad of RCC, right? Just going to have a tiny table to take care of this. These are pointers which I want you to remember for every cancer. Mutation, yes. Origin, if it is important, write the origin. Gross, microscopy. One more thing is IHC. RCC for an undergraduate, IHC is not required, so I ignored it, right? So we saw template for all your glomerulonephritis, right? This is a template for all the cancers. You'll have etiology, sporadic syndromic. You'll have clinical features. You'll have the mutation causing it. The origin, if it's like a glial tumor, okay, coming from astrocyte. Meningeal tumor coming from meninges. Breast cancer coming from TDLU, right? Gross, microscopy, IHC. That's more than enough. These are the 5 points I look for an exam. If you have the 5 headings, one relevant point in every heading, you're sorted for it. Fine. Yes, Sidhu, it will be in the app. I'll also share in the WhatsApp group and the Instagram group and PW's Telegram channel also. You will have it by default. Don't worry about it. Fine. Okay. What's a mutation for clear cell RCC? CRCC stands for clear cell RCC. It's same. Von Hippel-Lindau mutation, right? I'm going both with PCT, but Robin says DCT for papillary. It's, you write whatever it is. WHO goes with PCT, so I'm going with PCT. Fine. Your papillary is MET proto-oncogene or a scatter factor. Hepatocyte growth factor or the scatter factor is the reason for the it's a protein coded by MET proto-oncogene. Chromosome 3, great miraculous champ. If you want to add more, but this is basic minimum. Chromophobe RCC has lots of many translocations. Just write maybe hyperdiploidy. It's not one particular translocations. It can have a combination of translocations, loss and excess. So hyperdiploidy is something which is pretty common in case of a chromophobe RCC. If it's required, multiple chromosomal loss, sorry, not hyperdiploidy, hypoploidy. Chromosomal loss, not excess, it's chromosomal loss. Right? Multiple chromosomal loss can be there as a classical findings in case of a chromophobe RCC. Okay, collecting data of Bellini neoplasms. Again, it is a very rare thing just to fill the pages. That's all, more than enough. Not any particular mutation is seen in collecting data of Belliniasis, right? PCT, PCT, intercalated cells, collecting the ducts of Bellini. That's where they are raised from, right? Gross, it's more important for clear cell and papillary. Chromophobe also important. Collecting duct, like I said, it's just to fill the pages. Gross, more common in upper pole of the kidney. What will be the color? I'll tell you a template for the gross for any cancer from head to foot. There are few terms which is important in gross. There are few terms which will by default be present, right? One, whether it's capsulated or not. Okay, it's very simple. A high grade tumor, cancer, will it be capsulated, non-capsulated? Non-capsulated by default, right? Second, solid or cystic. Mostly a high grade cancer will be solid rather than cystic, right? Third, areas of necrosis and hemorrhage. HSG is for hemorrhage, right? Again, this is a template. You look for it, that's all. If you don't know what is there, fill something. It will give you 2-3 lines. Definitely 1 or 2 you'll be right, right? Necrosis and hemorrhage will be there in case of an high grade neoplasms. It will generally be absent in case of a low grade neoplasm. A low grade neoplasm will be generally more capsulated. A high grade neoplasm will be very invasive, right? This is how you classify gross template for any cancer from head to foot. Fine, let's go back. So it's more common in upper pole. It's more invasive or an infiltrative tumor. Like you said, it'll be yellowish in color because of the fat accumulation, and also it'll have areas of hemorrhage. And necrosis will be there because it's pretty high grade. Quite a few of them are pretty high grade. Papillary RCC, what is more important for me in gross is the multifocality. There will be multifocal lesions, not one, there will be multiple lesions because of the scatter factor, right? Chromophobe RCC, unfortunately, it's a very low grade neoplasm, right? It's very well defined. Okay, it's a well defined tumor. It has a brownish appearance, and one of the classical finding of chromophobe is the central scar. In gross, you'll have a central scar. That's a classical finding for a chromophobe RCC. Like I said, collecting duct, leave it. It's an irregular tumor with good amount of necrosis because they are very high grade tumors. Fine. Microscopy. What's a microscopy of clear cell RCC? It's not difficult, right? Clear cell RCC, you'll have clear cells, you'll have capillaries. Again, if you want to fill pages, you can easily fill pages. Can anyone tell me what are the 4 classical features of dysplasia? We read in a way which can easily fit in multiple things, right? Your pleomorphism, high NC ratio, mitosis, loss of polarity will be there in every cancer. Invasion of capsule will be there in every cancer. Those are template. You are stuck somewhere, use the 4 features of dysplasia. Don't write in like this. Pleomorphism. If you have more time, right? What is pleomorphism? Variation in size and shape. Very high NC ratio, right? Everything, right? So these are templates for you to make sure if you're stuck somewhere, we can come out of it. Don't use every time. It'll be a bad thing to portray that you are just blabbering something. Use in questions where you don't know head or tail of water, right? Clear cells, capillary is enough. Draw diagram. Put cells with abundant clear cytoplasm, and in between, good amount of capillary network. Again, like I said, what I want is representation, nothing else. Need not be an amazing picture, just a representation is more than enough. Papillary, you know papillary, how it looks. You'll have papillae. Whenever there's a papillae, what will be there? You won't forget it, right? Samoma will be there, right? You will definitely have papillae and samoma bodies can be there by default. Again, a representative image. Draw a finger-like projection. Tumor cells in a finger-like projection. Center of the finger-like projection, I'll have fibrovascular core. If you want, draw a thick samoma body here and mark a samoma body, right? Again, it's template. In addition to this, you can write pleomorphism, high NC ratio, mitosis, loss of polarity. That by default will be there, right? Chromophobe RCC, it has good amount of cells with pink cytoplasm. It's actually a very close differential diagnosis of oncocytoma, right? And a classical perinuclear halo. Again, draw multiple cells with amazing pink cytoplasm with a perinuclear halo. Yeah, Miraculous. Mahogany brown. I didn't say the word mahogany. Brown color, that's fine. Mahogany brown is the exact terminology used. Fine. Okay. Okay, a cell with good amount of pink cytoplasm and a clear halo in the center, right? So for drawing a halo, first draw the pink color and the center put a blue dot. That makes it looks like a perinuclear halo. Fine. Okay. Just for completion's sake, in case of an collecting duct of Bellini RCC, there will be excess amount of desmoplasia. It's a very, very desmoplastic tumor, very fibrotic tumor. And you'll have very pleomorphic cells with hobnailing appearance. Again, just to fill the page with hobnail appearance. Okay. For an renal cell carcinoma, you don't want to remember IHC or any stains. For undergraduate level, it's not required, right? So this gives a template. If only clear cell RCC is asked in a 5 mark, start with the same. Write the risk factors, clear cell only, right? Maybe use only this syndrome and maybe Berthold-Dubé, where also you can see clear cell. Abdomen features, abdomen pain, everything, clinical symptoms same. Only the first part. Write a bit elaborate, because I have tried for 5 marks. Write a bit elaborate, that's more than enough, right? If it's a random question on long question on carcinoma, explain the subtypes. Then draw a table if possible. That makes sense, fine. Yeah, Samantha. Pleomorphism, high incidence ratio, loss of polarity, and mitosis. These are the 4 features. ATP and pleomorphism both are same. You're right. Last but not least, cystic disease of kidney. Okay, there are 2 cystic disease which I want you to remember, which is ADPKD, ARPKD, which you know. Others are all incidental findings which might not come in a 5 mark or in an essay question, which might come in a 1 or 2 marks, which I'm sure you can easily fill it up. Fine. So if it's a cystic kidney disease on an let's say on a 5 mark, or very rarely it can come in a 10 mark question also, right? So pathogenesis of every cystic kidney disease is one and the same. It is altered ciliary function. The cilia is becoming abnormal. That's the reason I'm going to have lots and lots of accumulation, which is going to result in cystic kidney disease. If you've seen the Robbins, there's a beautiful flow chart for cystic kidney disease. That's the best thing, right? Whatever may be the mutations, I'm leaving here mutation of as empty. If it's ADPKD question, use the term polycystin mutation. If it's ARPKD question, use the term fibrocystin. If it's nephronophthisis, nephrocystin, whatever it is, change accordingly, because pathogenesis is explained in Robbins and ADPKD. There's the same pathogenesis for everything. Whatever there's mutation of that particular thing, fibrocystin or nephrocystin or polycystin, whatever it is, it will alter cilia's function. That's the most important thing, whatever mutation it may be, right? If the cilia function is altered, this causes lots of disturbances. One, it alters calcium influx and efflux. Okay. At the same time, it will also alter the polarity, because it's very important. The cilia is important for the polarity of the tubular epithelium, right? It alters the polarity, growth, and differentiation of tubular epithelium. We did read in detail what it is meant by, but there's something just to fill up for us, right? If the growth and differentiation is altered along with the alteration of polarity, which obviously will result in abnormal proliferation of cells. It's alteration in growth, right? So it will result in abnormal proliferation of cells. I need to have a cyst. So by default, I'm going to have, with the help of this also, excess fluid secretion. The cyst automatically needs a space. If it's becoming big, something should hold, right? And an abnormal matrix, abnormal extracellular matrix, right? All this will result in cyst. This is the same pathogens for every cystic kidney disease. If it's ADPKD, polycystin, ARPKD, fibrocystin, nephropathy, nephrocystin, Euro model for different diseases, right? But every cystic kidney disease, the pathogen is the same. mutation of that particular disease, whatever the question is asking for, alters ciliary function. Cilia alters, calcium flux will be altered. It's very important for maintaining polarity. So growth differentiation will be altered. If growth differentiation altered, I'll have abnormal cells, more fluid secretion, abnormal matrix, which results in a cyst. That's all fine. So ADPKD and ARPKD are something which is very important. If you want to add more, write inheritance, autosomal dominant, autosomal recessive, just to add pages, that's all, right? If you want to add more with classical features, elderly presentation, this presents in children. Actually, this gives us multiple things. I have multiple variants. I have a variant called as an infantile variant. We have neonatal. We have juvenile. Based on the age of presentation, I have different types of ARPKD. Very, very early, even before birth. Perinatal, neonatal, infantile, juvenile, right? Mutation fibrocystin 1 and 2, polycystin 1 and 2. Fine. Those are the mutations here. Okay. Large multistic disease in kidney, liver, and also berienism in the brain. Here you'll have enlarged kidney, liver cyst, and also fibrosis. Some of you guys said classical presentation is hepatic fibrosis, right? More classical feature, it will be present at birth, it will be present at elderly. You can have hypertension also in ADPKD. You can have hematuria, everything is in ADPKD as well, fine. Gross cyst on both outer and cut surface. Draw a diagram. Most of cyst will be oval to round. You'll have cyst on the outer surface and cut surface. Cyst will be oval or round. Cyst can by default have hemorrhage in them. Cyst can also have calculi because it's a stored fluid. Definitely all the calcium, everything will be stored. It can result in a calculi formation, right? Cyst on ARPKD will be only on the cut surface, and most classical cysts are oval, elongated, they will not be round. And most importantly, they are perpendicular to the surface of the kidney or the cortical surface. The cyst will be like this. It will be perpendicular to the cortical surface. That's a classical presentation of an ARPKD. Make sure it looks like a kidney, fine. Outer surface, cut surface, only on cut surface and elongated, right? Complication of ADPKD, both of them will not cause cancer. That's not going to be the complication. The thing is, it can get infection, right? You can have an UTI, definitely can complicate. You can have renal stones. Because of the renal stones, it might result in hematuria, pyelonephritis. All these can happen, right? Not just UTI, it can also result in pyelonephritis. It will not cause cancer. Only one kidney disease, cystic disease, which can cause cancer is acquired cystic disease, right? Here, the biggest problem for us is the renal and hepatic failure, because hepatic fibrosis is very common here. So renal and hepatic failure, which might even be the death note for the patient. That's the reason for that's the complication or the outcome for an ARPKD, fine. Yeah, berienism also you can write as a complication, which can cause your intracranial hemorrhage, subarachnoid hemorrhage, not intracranial hemorrhage. Okay. We have put that in clinical features, so I didn't add it here, fine. Okay, so that's about an ADPKD and ARPKD, fine. So that's for today. I'll make sure I'll try to complete in 1.5 hours. In the next, whenever we have the next Farre, I'll do one thing. From morning of that Farre, most of you must have your leave. I'll put the topics, what to be read. I'll put the time on what to be read. I won't ask you questions there, just self-study, right? Again, we'll come by 7:30 of that day and have the same template-based learning. I will add this empty thing. It's already with you. If you want to write notes with that, or this will be added to the app as well, right? This annotated thing also will be there in the app as well, fine. There's a WhatsApp group. It's full, so I'm not creating one. Just there's a Insta channel. I think it has more people who can join there. Please join there, fine. Samantha, this is a short thing, right? Definitely, see, it's very difficult for me to cover the entire pathology, so I'm going for the higher yield ones. Vascular disease, renal stones, please do a self-reading. Whenever you have a doubt, do let me know. Okay. All the best, Miraculous Cham. Fine. So you have the Farre available for you in the app as well. If you've not noticed that, please go and have a look at the Farre 2.0. We have 8 modules. I think one 5-mark question comes in 8 modules, right? So take care of that also. Read that. Exam is not a worry. Our goal is bigger thing. Our goal is always big. Never the exam, never need PG, never next, never FMG or USMLE, right? We'll read well. Unfortunately, we have to change a little bit in the next 1 month. We know a lot. We have to present it so that we know the examiner also knows that we know a lot. That's the goal of Farre, fine? All the best, guys. Thank you. If there's any doubts, do let me know. If not, let's call it a day. Okay, guys. Thank you.